So things that you're going to be learning today during this course is basic pelvic floor anatomy, functions of your pelvic floor. We're going to learn how to Kegel correctly. We're going to learn the importance of your diaphragm. We're also going to learn how to activate your transverse abdominis. We're also going to go through some pregnancy dysfunctions, and then we're going to teach you some different birthing positions you can do in stage 1 of birthing. You're also going to learn how to push and the difference of stage 2 labor. And then we're going to learn some exercises you can perform hours after giving birth, and then some fun facts and myths. Hi, my name is Ashlea Lytle, and I've been a physical therapist for 13 years. I graduated from the University of Kansas and moved out here directly right after graduation. I've been treating more pelvic health dysfunctions for probably about the last 6 years of being a physical therapist. A little bit about my story: I decided to start treating more pelvic floor dysfunctions because a lot of my clients at the time I was treating for low back pain, and they're having some urinary incontinence, and they end up having to see another pelvic floor specialist that was treating more pelvic floor issues that I couldn't see anymore, and I just wanted some continuity of care to be able to do this for my clients. And then I also have had 2 children. I've had 2 vaginal births, so I've gone through what you guys are going through right now, and I just want to get the word out there of things that you can do to kind of help prevent some of these things that could happen in the future, and then just to really make you guys have the best pregnancy that you can have and the best delivery process, and kind of just know some facts and myths about labor and delivery and some of the things that I learned that I didn't even know as a pelvic floor therapist going in and delivering my baby, my 2 babies. So I just wanted to let you guys know a little bit more about me and why I started treating pelvic floor.
Hi everyone, my name's Kylie Faildo. I am a doctor of physical therapy. I am pelvic health trained, and I have my pre- and postnatal corrective exercise specialist certification. Here are some of the courses that I have taken. I received my bachelor's in human development and family studies with a minor in women's studies from Colorado State University, and my doctorate in physical therapy from California State University, Long Beach. I started my career working primarily in orthopedics, treating diagnoses ranging from post-surgery to various sports injuries. I then developed a passion for pelvic floor PT after working with a number of individuals who have had children, and I wanted a deeper understanding of how the pelvic floor influences other musculoskeletal structures. Prior to my career, I was a social worker, helping individuals receive various support services. I loved working one-on-one with clients, but I needed a career that incorporated my love of health, wellness, and the intricacies of the human body. And physical therapy just happened to be the right fit. I believe that movement is medicine, and I'm passionate about helping people reach their personal and fitness-related goals. I love working with the pregnant and postpartum populations, athletes, and really anyone in need of pelvic floor physical therapy.
Hi, my name is Chelsea Speegle. I'm a physical therapist. I've been practicing since 2017. The majority of that time I focused on pelvic health. I treat women's and men's health. I focus more on prenatal and postpartum rehab. A little bit about how I got into pelvic floor therapy was I started off in orthopedics, treating hip pathologies and back pain, and noticed the influence of the pelvic floor. From there, I decided to pursue more into the prenatal and postpartum rehabilitation. I'm a mother of 2, so I've been pregnant, I've exercised through pregnancy, and then I've gone through, obviously, the postpartum recovery process, and have struggled with pelvic floor dysfunction myself. So I definitely relate to a lot of my patients, but I've returned to all the activities that I have wanted to do and the activities that I did before I was pregnant with my first baby. And so I love educating patients. I'm very passionate about pelvic floor. You can ask me any question, and there's no such thing as TMI for me. But I'm really excited to go through this presentation with you guys to help with labor and birth prep, and even going through some gentle exercises that you can begin immediately postpartum.
So let's first talk about what is your pelvic floor. So let's go through the bone structures of the pelvic floor. You have what we call your ilium, which is your hip, like we more refer to your hip bone. So if you put your hands on the outside of your, like the top of your hips, you can kind of feel that bony prominence right there. So that is called your ilium. That is part of your pelvis. And you also have your ischium, which is more of like your sit bone, the bones that you sit on. And then you have your pubic bone, which is right in front. And that pubic bone sometimes can get very uncomfortable because as you're pregnant and you start to get more of that relaxing into your system, you have a ligament right there between your pubic bone that starts to kind of soften up a little bit, and so that pelvis can widen. So then you're able to push the baby out and the baby's able to fit through there. So that's why a lot of times during pregnancy right now, you could be dealing with some pubic bone pain. And there's exercises that we can do to show you to kind of help more stabilize those muscles or in those bones a little bit more. So definitely reach out to us if you're having some pelvic pain. But I think later on we will go through some exercises of that. And then you have your sacrum, which is the blue portion right there. So a lot of times that sacrum, so where the sacrum and the ilium come in together, is what we call your SI joint. So that SI joint sometimes can be very unstable as well because it's supported by ligaments back there. And as you're pregnant, you're more relaxed and gets into your system, and those ligaments get very relaxed, as relaxing is called. So when it gets a little bit more relaxed there, a lot of times you have more instability because your muscles aren't strong around there. So then you start having more back pain. So that's where that, what we call that SI joint pain. So SI, sacrum, ilium joint pain is at there. And then, of course, your lumbar spine, which is not shown in this picture, but lumbar spine would sit right above the sacrum. So we kind of look at all of those bony structures when we're looking at your pelvic floor. So we aren't just looking at the muscles, but we're looking at all the bones around there to kind of see like, okay, what alignment are they in? Is something rotated? Is something, not, is there muscles around it that's not stabilizing that bone? So that's why it's rotated. So we look at all that stuff. And then of course you have your coccyx bone right there too, which can sometimes get in the way of labor. So we always make sure that coccyx bone is in good position. And sometimes you can damage it with labor, but we always look at all those bones and we just look at the alignment to make sure things are moving correctly. The next part that we usually assess of your pelvic floor is, of course, your pelvic floor muscles. So there's a lot of muscles around here. It's not just the pelvic floor muscles, but we also look at your transverse abdominis, which is the muscle in front. It's that muscle that kind of hugs in that baby. And we'll go through kind of how to correctly contract this muscle. But we look at that muscle. And then, of course, your pelvic floor muscles, which is crazy. There's actually 11 muscles on each side. So there's actually 22 muscles of your pelvic floor. It's crazy that there's that many muscles, and they all have a certain job to do of the pelvic floor. So we want to look at those, and how to do that. We do internally palpate to kind of feel those muscles and see how they're activating. And then another muscle we kind of look at sometimes is your multifidus, which is the muscle that runs up and down your spine. It connects each of your spinal segments together. So we always want to make sure that those muscles are firing correctly. And then the last muscle is actually your diaphragm, which sits up really high. It's not shown in this picture. But your diaphragm, we want to make sure that you know how to expand your diaphragm and move it in all different directions, because that's going to, number one, help you push that baby out, and two, help you create stability in there to kind of decrease any back pain, any round ligament pain, any pelvic floor pain, any urinary incontinence. Diaphragm is very important for all those things. So those are big muscles that we look at when you come in to see us as your pelvic health providers. Now let's talk quickly about the functions of your pelvic floor. There's four main things of what your pelvic floor does. First one is, of course, it eliminates urine and feces. So you're able to pee and poop from your pelvic floor muscles. It's provided there for sexual intercourse. So think about those muscles. There's muscles that go into that clitoris that kind of help orgasm and help arousal. So it definitely helps with more arousal when you're having sex. And then it is our foundation of our core. So a lot of times pelvic floor, when it's weak and not working, that's when a lot of times we can have back pain, we can have pelvic pain. So it is our foundation of our core. And then it's there for vaginal delivery, right? So those muscles have to relax, they have to move to be able to get that baby out. Now learning how to Kegel correctly. Some verbiage that you can use, or that we use to help a client learn how to Kegel, is think about holding in your urine, holding in gas, bring your pubic bone towards your rectum, Something we don't yet like to use is stop your urine flow. The only reason is because I don't want you to practice stopping urine flow on the toilet, because your bladder will really catch on to that, and then you'll train your bladder incorrectly. Two different things that you should learn how to Kegel is you want to learn how to Kegel slow endurance Kegels, which is Kegeling for a long period of time, so like 10 seconds. And you also want to learn how to quick Kegel to kind of fire those quick twitch Kegels. So that's more of a Kegel up, relax down, Kegel up, relax down. In the next slide, you'll actually see some Kegeling. And then also we want to learn how to drop your pelvic floor. So this always helps with passing gas, passing a bowel movement. And then with Kegeling, we kind of throw in belly breathing there because that will help drop your pelvic floor as well. So let's go to the next slide and let's practice how to Kegel correctly.
There are several ways to Kegel. One way is a long endurance way. You want to be able to hold your Kegels for 10 seconds without letting go. Try practicing first laying on your back. And if you feel like you get this connection, then you want to try doing it in sitting and in standing as well. Next, try short, quick Kegels, Kegeling all the way up and all the way back down as fast as you can go, but make sure you fully relax between reps. Lastly, you should be able to drop your pelvic floor. So this is opposite of Kegeling. You can see here as my belly rises, my pelvic floor drops down. This helps with pushing a baby out. This will help with constipation. Make sure when you're Kegeling, you don't squeeze your glutes or your adductors.
Okay, we're going to talk about breathing. So we call this 360 breathing because we want to be able to breathe through our whole diaphragm. In this video right here, you can see that I'm breathing into my belly. So as you see, my left hand is not rising and just my right hand is rising. And you see as we breathe in, you want your belly to rise. And then as you breathe out, belly comes back down. Now, most of you guys are probably pregnant right now, so it's going to be hard to lay on your back. You can do this in any position. I just showed you on my back because it's a very easy way to show the expansion of my belly. And as you can see in these next few breaths, I'm doing it incorrectly. So I'm actually breathing up into my chest, and you see my chest rising a little bit more and then coming back down. And that was a kind of incorrect breath, that last one. This next one is a lateral chest breathing. Okay, so this is easy, you can do on your sides. So just put your hand right on your side of your rib cage. You don't want your belly to go out. This is where you really want to expand that rib cage to one side. So you can see as I'm breathing here, I'm really getting that breath into my side of my rib cage. And then letting it come all the way back out. This is going to be really important postpartum to get this lateral rib cage to really move. And you want to do both sides here. And you'll see in this next little part of the video, I do both sides. So you can kind of see both directions, how my lateral rib cage rises and how it falls back down. So you want to get good expansion into the rib cage here. And you can do this in any position. It doesn't have to be laying on your side. I just think laying on your side might be comfortable, and you can actually feel that ribcage move a little bit more with that hand. So you should be able to direct your breath 360 degrees around your waist. And then this last video is a good way, so go into child's pose, and is a good way to see your lateral or your back of your ribs expand. So here I'm breathing into the posterior portion of my rib cage and getting the posterior back to move a little bit more. So it's a very good way to kind of get that breath more into your back and not necessarily in your belly. So this is where you don't want it in your belly. You don't want to be breathing up into your upper chest. You want to be breathing into your lower back. So these are the 360 breathing.
Okay, so I'm going to talk you through how to activate the transverse abdominis. This muscle is really important because it's actually a stabilization for our spine and our pelvic girdle. It acts like a corset around our trunk. And I want to briefly go through with you the anatomy of the abdominal wall so you can understand how all the muscles fire in different ways. So your rectus abdominis and your obliques are your big primary movers. They do more of the movement in regards to your core muscles. So the rectus abdominis is that six-pack muscle that many people know of. The muscle fibers run vertically, so from the rib cage down to the pubic bone, and they do more of a crunching, bending motion through your spine. And then we have the external and internal obliques, which do more of the like twisting, side bending, again, big movers. And then that transverse abdominis is that stabilization muscle. It's that corset. The muscle fibers run horizontally. So essentially the spine and the pelvic girdle should not really move with us. So a couple with this activation. So a couple cues that you can think of is pulling your belly button towards your spine. But I also like the headlights a bit better. So thinking like your two hip bones in the front, and you want to think of drawing those two hip bones together, again, without like tucking or moving your pelvis or your spine at all. Blowing all of your air out, using the diaphragm and breathing actually is a huge contributor to activating this transverse abdominis. So you can do an inhale through your nose, exhale through your mouth, thinking of like a shh motion, like your shushing sound, and or you can blow out of your mouth like pursed lips, like blowing out a candle. And then you can do this in hook line, quadruped, and even sideline. And then we're going to go through some videos with exercises to help get this muscle activated and even challenge it, like marching, bent knee fallouts, bird dogs, and seated marching. Okay, so this is a seated transverse abdominis activation on an exercise ball, and we'll also show the progression of adding some marching with the legs. So you'll inhale through the nose, exhale through the mouth, and then activate that transverse abdominis, hugging that baby, and then gently marching up those knees with as minimal to no movement as possible through the spine and the pelvis. The ball provides an extra challenge of stabilization because you're a little bit more off balance on an exercise ball compared to a normal chair. So if this is too hard, you always could try this on a chair and then progress to the ball. But again, that focus is maintaining that transverse abdominis activation. And then here we're also going to demonstrate some patterns that you don't want to do. So this is what an improper stabilization on the ball looks like, where your spine is moving, you're twisting and turning. So you're really trying to stabilize between that rib cage and the pelvis using that transverse abdominal muscle. And so you can do this 1 to 3 sets of 6 to 10 reps, depending on what you can tolerate, and make sure that you're maintaining a normal breathing pattern through the whole exercise. This is transverse abdominis activation in 3 different positions. So starting on hands and knees with a neutral spine and pelvic alignment, you want to inhale through your nose, expanding the rib cage and belly. Exhale through your mouth as you think of hugging your belly and your baby towards your spine without moving the spine or the pelvis. While you maintain this muscle activation, keep a normal rhythmic breathing pattern and hold this for 10 seconds. Next, you can do this in sideline and do this on both sides so that you can get each side activated. So with this one, you're going to inhale through your nose again, expanding that rib cage and belly. And as you exhale, think of exhaling all the air out as you hug that baby towards your spine. Again, avoid movement in your spine and pelvis so you're isolated on that muscle activation. Hold this for 10 seconds with a normal rhythmic breathing pattern. And the last one, if you are able to, or if you're early on your pregnancy, you can do this laying on your back as well. So again, you're going to inhale through your nose, expand that belly, relax that pelvic floor as you inhale, and then exhale, think of bringing those two headlights, your hip bones together, or hugging that baby towards your spine. Avoid tucking with this position or arching your back. Hold for 10 seconds.
Now let's talk about some prepartum dysfunctions. First, we'll cover urinary incontinence. Under these, we have stress, urge, or mixed incontinence. Stress, you can think of leaking when you are coughing or sneezing or jumping or running. Urge, you can think of feeling that initial urge to go and then not being able to control it and having a leak. And then mixed is a little mixture of both. Pregnant individuals can also experience pubic symphysis pain from an increased instability due to an increased production of the hormone relaxin. They also might experience some increased constipation. Some things that we can do to help ease this would be working on our bowel mechanics, so incorporating things like a squatty potty or something to step on while you are sitting on the toilet so that your knees are raised above hip height. We can talk about things like diet, incorporating more fiber, and then increasing your water intake. You may also be experiencing some pelvic pain. You could have some pain with intercourse, and this generally should not last longer than 2 to 3 months postpartum. And I'm sure you're all aware of low back or SI joint pain during pregnancy. And again, this is due to an increased instability due to an increased production of the hormone relaxin, as well as just some other muscle imbalances that may be going on.
Okay, so let's go through non-progressive versus progressive labor. Non-progressive labor involves Braxton Hicks. So these are contractions that occur the last 4 to 8 weeks of pregnancy. You know they're not true contractions because they're irregular. They're not consistent. So they may have, you may have one contraction that happens one day and then it won't happen again till a couple days later or a week later. Also, it will increase in frequency and intensity towards the end of pregnancy. So the closer you get to your due date, you're going to feel them a bit more and they're going to happen more often. And then intensity of the contractions changes with activity, rest, and warm bath. So that would mean if you get into a certain position or you start walking around and then the contraction pain eases or it eases with rest and a warm bath, and you know that it's more Braxton Hicks related rather than true contractions. And then also there's no changes to the cervix. So there's dilation of the cervix versus effacement. Dilation is when the cervix is starting to expand in diameter, which goes from 0 to 10 centimeters. And then effacement is more thinning of the cervix. So we're looking more at effacement when we're talking about changes to the cervix during non-progressive versus progressive labor. Dilation, you can actually start happening. It can start happening around 36 weeks, and it's going to be really small, more like 0 to 2, and it can stay the same or it can increase. But if there's no changes in the effacement, that thinning of the cervix, then you're not in true labor yet. So when you have that checkup with your doctor, ask them about the effacement rather than the dilation. And then with progressive true labor, there's 4 different stages. And so there's latent, active, and transition phases within the first stage. And this has more to do with how regular the contractions are occurring, how long the intervals are, and also the duration. So through each phase, starting with latent, it's going to be more like the cervix is dilated to up to 4 centimeters and you're fully effaced, and the contractions are a bit more mild. They're going to be more spread apart, so about every 5 to 7 minutes with a duration of 30 to 40 seconds. And then it progresses through active and then transition. By that time, the contractions are going to be shorter, every 1.5 to 2 minutes, but they're going to be longer in duration, so 60 to 90 seconds. And this varies person to person. Second stage is that urge to bear down, feeling like you're ready to birth the baby. And then third stage, perineal repair and placental delivery. Fourth stage is the postpartum monitoring afterwards, making sure there's no other complications. And again, progressive true labor involves contractions that are regular, intervals shorten, and duration increases. And these contractions do not change despite the rest, the heat, or activity that you do. These next 2 slides, we're going to look at examples of different birthing positions. So these positions are going to be more for laboring. It's best if you talk with your medical provider regarding certain positions you want to birth the baby in. Since they have a high liability rate, there might be certain positions that they don't feel comfortable with, or they might feel completely comfortable, but it's best to discuss this with them. And then also, how do positions affect labor and birth? So a more upright position can actually promote progression of slow labor, while lying positions can slow down rapid labor. So keep that in mind if you feel like things are going too fast and you need to slow down a little bit. Maybe you need to be more in a lying position, or if you've been laboring for a while and need to speed things up, try some of the more upright. Positions also depend on whether you have an epidural or not. If you have an epidural early on, then you won't be able to do any more of the weight bearing positions, like being on your knees, even like a deep squat, but laying down on your side are completely doable with labor positions. And someone can help you with any holding of legs if you need that. So we've got a couple here where we're on the knees and also deep squat and sideline. And I want to talk about the benefits of any pains or dysfunctions that you might have and what positions you might want to consider laboring in. So hands and knees and kneeling positions help with SI joint dysfunction, pubic symphysis, tailbone pain, disc issues, and also hip pathology. And then sideline is going to be better for tailbone pain, disc, spinal stenosis, and also hip. This second slide shows many of the same positions from the first slide. It just uses a peanut ball. A peanut ball is usually available in many hospitals and birthing centers. Nurse midwives and doulas might also carry them if you're having a home birth. Just makes it a bit more comfortable in terms of positioning, just because of it's a little bit longer than an exercise ball. It also has a dent in the middle that you can wrap your legs around. And same thing also, going back to the first slide of, positions that may benefit any musculoskeletal pains that you might be having and you don't want to worsen them. Whether you're laying on your side and you want to help with any tailbone, disc pain, spinal stenosis, or hip dysfunction versus quadruped and kneeling positions. The other thing is we encourage patients to change positions every 10 to 20 minutes just to keep the body moving. And also it helps with contractions if you're changing positions rather than staying in the same spot.
Now that we showed you a lot of things for that first stage of labor, let's talk about second stage of labor. So your second stage of labor is actually when you're pushing, okay? So the biggest thing to really use when you're pushing, one, you want to push on your contractions. So, when you have an epidural versus a non-epidural, you're going to feel, or non-epidural, you're going to feel those contractions. So you know when to push, because really that contraction of that uterus is really kind of what's helping to push that baby out. When you have an epidural, sometimes you might not feel that, okay? So you really have to focus on your diaphragm and really using your diaphragm to kind of help push everything down and push that baby out. So what we learned before of that diaphragm breathing and really kind of expanding that belly and really expanding the rib cage and then really pushing that belly out to drop that pelvic floor, that's what you really want to focus on. So in this next video, I'll show you kind of how to use and what it kind of looks like when you're pushing. Now, in the video, I'm not pregnant, so it's hard to kind of see what it would really look like, and I'm in no pain. I'm just sitting there, but it kind of gives you that idea of really how to use the diaphragm. And then you want to learn how to drop your pelvic floor, which if you learn how to use your diaphragm, your dropping of your pelvic floor is going to happen. So just think about, they always like to use the term like you're pooping. So a lot of nurses, when you're in there, they'll go through and say, hey, just push like you're pooping, okay? So you want to kind of think of that, of dropping your pelvic floor, because if you have that epidural, you might not feel that. So that's why, again, I go back to the diaphragm. It's really important if you have that epidural. Then I'll go through this in this video of holding the breath versus not holding your breath. There's a lot of research that is starting to kind of go more towards don't hold your breath, because maybe there's a correlation to less tearing. I still think there needs to be a lot more research behind this. So I've had 2 babies. My first baby, I held my breath, and because I remember this is what I didn't know, and I should have known as a pelvic floor provider, but it's just something I've never experienced. And I remember going in, and I remember they're saying, okay, like, breathe in now, hold your breath for like 10 seconds and push at the same time. And I remember her 10 seconds, she was counting 1, 2, and I thought I was going to pass out. So I decided with my second one, I was going to do this more open glottis technique, which is more of not holding my breath and keeping my breath going. And I still was able to push my baby out in like 20 minutes, I think. I know it was less than 30 minutes, but I can't remember the times. So either way, the nurses, I will say, and the doctors know if there's an emergency and they need to get that baby out really fast. But just know that you can still push that baby out pretty well, both directions, both ways. And I do feel like I wasn't as worn out when I was breathing. So I felt like I could breathe a little better. Now, I did tear more with my first than my second. I really don't know if that has the correlation to do with my holding my breath versus not holding my breath, or if it was because of my first baby versus my second baby. So I don't know, but I do know that I did hold my breath that first labor and pushing, and then my second one, I did do more of the breathing pattern. So we'll go through that a little bit of what both looks like. And again, you can choose what you want to do. I will say the research is starting to go more towards not holding your breath and kind of breathing through it a little bit more, but understanding really how to use that diaphragm. And that's what you can start working on now, is getting used to that diaphragm and really breathing that air in and expanding that diaphragm. And then we've already kind of talked about, pushing on contraction, epidural versus non-epidural.
Okay, so this presentation has been mainly focused on pregnancy and childbirth preparation, but we also wanted to touch base briefly on exercises that you can start off with the day that you deliver your baby or the day after up until that 6 weeks. We do like to see patients come in the first 6 weeks after birth just to get them going on exercises and teaching their muscles how to activate again after having this event to the body and after growing that baby for 9 months. So here are some examples, and we'll have videos of these exercises provided as well. So the first one is light Kegels, and what we mean by light Kegels is you're not going with full complete effort. It's going to be more like 25-50% effort, because you don't want to completely tighten up that pelvic floor. You want to also allow it to relax as well. Sideline diaphragmatic breathing is a huge one. After, baby expands in your belly, your rib cage widens. So breathing actually can be either difficult or it can not be complete in regards to the mobility of the rib cage. So starting that off, getting that big inhale through your nose, expanding the rib cage, and then exhale, allowing that rib cage to completely relax. It can also help benefit the pelvic floor working on the breathing. Hook line, isometric hip abduction and adduction. So isometric is any exercise where you're activating a muscle, but you're not necessarily moving the body part itself. So hook line is laying on your back with your knees bent. And for the abduction and adduction, all you need is a ball between your knees and either a Pilates ring, a belt, or a super heavy resistance band around your knees. And again, we'll have a video of this showing, but you can gently press those muscles in and out, and that engages more of your hip muscles to stabilize your pelvic girdle. We have light transverse abdominis contractions. So remember that transverse abdominis is that deeper core muscle that helps stabilize your spine and your pelvis. You can perform these in a hook line position, so on your back with your knees bent, in a quadruped, so that's hands and knees position, and also sideline positions. Walking is really good after having a baby. It gets the blood flow going. It's also very functional. And we usually recommend that you start walking for short increments and then progressively increasing them based on how you're feeling. If you're a runner or you're someone who wants to get back into sports activities, it's really good to walk for at least 30 minutes without pelvic floor symptoms before starting to progress into some of those higher impact activities. And then we have a single knee to chest stretch, which you bring your knee up to your chest and then your other leg is straight out. And the leg that's straight out, you can activate that glute and you're getting an isolated glute contraction. And again, we'll have videos of all of these exercises with instructions. This is hook line isometric hip abduction and adduction. First, you'll inhale through your nose and then exhale through your mouth as you activate your transverse abdominis and perform a gentle Kegel while gently pressing into a ball, holding for 10 seconds. And then you'll alternate pressing into a Pilates ring or a belt gently, holding for 10 seconds. And then you're going to repeat this 1 to 3 sets with 6 to 8 reps, and don't forget to breathe. This is the single knee to chest stretch. So you're going to bring one knee up toward your chest and the other leg is going to be straight. The leg that is straight, you're stretching out the front of your hip, so your hip flexor muscles. You can increase that stretch by activating the glute muscles of that straight leg and holding it for 20 seconds. And then you can switch legs and repeat the same thing, holding for 20 seconds on the other side, and then repeat this 2 times.
Some fun facts and myths about pregnancy and delivery. First one is you can get up and walk when you're in the triage room and being monitored. That I do want you to know that you can get up and move around. You can walk out in the hall if they let you walk out in the hall, but do not just lay there in bed. If you can, try to get up, move around a little bit. If you're having contractions, they will figure that out and they will admit you. Next one is you can bring your breast pump in and make sure that you are sized with the right flange. And yes, do bring your breast pump in if you aren't sure what flange size you should be using when you do breast pumping, if you decide to do breastfeeding. So you can bring that in and the lactation consultant will size you up with the right flange, which is those pieces that come with your breast pump. There's different sizes. So if you aren't sure, just bring the whole thing in. If you can just bring the sizes in, they can always size that up for you. Third one, you can deliver on your back with or without an epidural. I would say with an epidural, you are limited in some positions just because safety reasons. But if you don't have an epidural, there's a lot of different ways that you can deliver. A good one is kind of in a squat position if you really wanted to. You can deliver on your hands and knees. So kind of explore that a little bit more if you decide not to have an epidural. Peeing with laughing and jumping after giving birth is normal. No, that is not normal. I'll say you might have some leaking within the first week or two once tissue is really healing, but really after 6 weeks, you should not be peeing anymore when you laugh or cough or jump. I know a lot of moms that are, 2-3 years postpartum or even longer than that, 20 years postpartum, say that they always pee their pants when they're jumping on the trampoline. That should not be happening, and that's actually something we can help with in pelvic floor PT. I think that's the fifth one. They will push on your belly after you deliver to remove blood clots. And yes, that's true. That's something I didn't expect them to do after I delivered the baby. So when they come back in, they will come in every so often to kind of just push on your belly to kind of get all the blood clots out and make sure that everything in there is moving normal. And this one, you should only eat red grapes while you're pregnant. Yeah, that's not normal. Okay, you can eat green grapes and a lot of other foods. So if you feel like that's something that somebody told you, then please disregard that. And this next one is your pelvic floor muscles are what push out your baby. And no, that is not true. Actually, your uterus is contracting. So as your uterus contracts, that's actually kind of really what pushes that baby out. That's why when we talked about how to push a little bit earlier, we talked about pushing on your contraction, because that's actually going to help. You don't really want to push when you're not contracting. This next one, exercising, especially your transverse abdominis, are important during pregnancy. And yes, this is why we went through all those exercises of things that you can do starting right now, and then the exercises you can do directly after delivery. You cannot have intercourse during pregnancy. That's false. You can have intercourse up to the day that you deliver. And if you have a DRA, which is that diastasis recti, so that's a separation of your abdominals, the only treatment is surgery, and that is not true. There's a lot of different things that we can do as PT, and there's a lot of other type modalities out there
that actually can treat the separation of your abdominals. So just know that you don't necessarily have to have surgery. And then everyone should see a pelvic floor specialist after labor and delivery. And yes, I agree that everybody should come in, at least get assessed. Doesn't mean you have to do that many treatments. If you come in and get assessed after you deliver, most likely maybe we can help you with not leaking, with not pain with intercourse, good tissue healing, prolapse, things like that might happen after you deliver that baby, especially vaginally, and even C-section scars. We can work on getting those muscles to recruit back and to get you back to your best self and moving and without having pain.